I hope to talk for about half the time and then reserve about half the time for listening and feedback and discussion. And we'll see how that goes. So a quick disclosure, I received support from Digital Health Solutions and Pfizer before. Just to set the groundwork for learning health systems, this is something that we have heard many times from this in the same arena. Briefly, a learning health system is one that engages learning health communities in learning health cycles. These cycles are supported by a common platform, a common infrastructure involving people, processes, and technologies. There can be different cycles attacking different problems that go faster or slower, but each one will need some community that takes the knowledge out there, implements it into performance, takes that performance into data, and translates that data into knowledge. So the use case that I am working in right now is in case or care conferences. You'll hear it differently depending who you talk to. I'll use care conferences from here on out. I'm going to borrow a definition from one of our colleagues, Josh Vest, about case conferences being collaborative team meetings during which providers trained in medicine, behavioral health, and social services identify and address patients' social, financial, legal, and medical needs. Briefly, these are team-based care meetings that meet the needs of complex patients outside of their regular 15-minute appointments. In a brief conceptual diagram, and this is off the top of my head, there's no huge validity study behind this or anything, but just to kind of describe the relative concepts, we have here we go. Population health in the broader circle. Part of that involves a care coordination. Within care coordination, there can be care conferences with these groups of people meeting together, this team-based care. A shared plan of care is key to care coordination to make sure everybody's on the same page. And patient goals are a key component of shared plans of care. So not only is this patient goals, shared plans of care, they're part of population health. These are all an implementation of team-based care, which is a big thing we're working towards, is try to reduce burnout and better engage all the team members in healthcare systems. So the goal that I am trying to accomplish within care conferences, and my setting is at Eskenazi Health, specifically in the ambulatory space or the outpatient space, is to align, communicate, and collaborate to create an intentional learning system for care conferences. And of course, learn from it and iterate and become better and continuously study and improve. The key features that I hope we develop are flexibility through minimum specifications, sustainability, which is a huge thing, especially a financial sustainability, as well as implementing sensors or measures built into our routine workflow that capture that data that we can translate to knowledge and re-implement to improve performance. So a brief history of care conferences at Eskenazi Health. They started around 2014 with a text template in the homegrown medical system, G3, or just the interface to that system, G3. It was just, they think of it like a text macro, just pre-formatted text. It was used within ambulatory pediatrics. Since then, there's been a lot of organic growth and development, as well as a lot of waxing and waning. So it's not done everywhere. Some people do it more than others. There have been several interactions with researchers and with other groups, especially internal to Eskenazi and quality improvement efforts. In 2019, and even currently, some people are trying to reach out to alternative or different funding models that we haven't approached previously. Some of the evaluations that have been done include in 2016, there was a descriptive analysis and a association test for care conferences with cycle time and health outcomes. It was a QI type of project. It wasn't super rigorous and it didn't get published out. In 2017, Sarah Roth, who's here with us now at Regenstrief, reviewed about 1,500 case conference notes to determine the descriptive statistics about what is happening in case conferences, and that was also part of QI work. In 2018, Josh Vest published about case conferences that involved public health nurses from the public health department. In 2020, or most recently, I know Josh Vest and Val Yeager from our public health school have also been looking into how these case conferences are happening and gathering data on those. One thing that we have now, though, is a specific gap in understanding patient goals, which are a key component of these care conferences and shared plans of care. One of the key things that Sarah Roth had identified in these notes that from care conferences, as well as talking to the providers or the teams involved, was that they needed a better documentation workflow and better clarity on how to document their goals. So the next steps that I've arranged are for a care conference summit happening on March 18th. It'll probably be here, but some of that's to be decided. And just as an aside, if anybody is interested in participating in that, please let me know and we can add you to the list. At that point, we are convening key stakeholders, including health system, providers and leadership, academic folks, government and payer entities, patient family representatives, community organizations, to help to put down an intentional plan of how we are going to do care conferences at Eskenazi. So that is part of the care conference part. The part that I am particularly focused on, and hopefully can get more feedback on from you all, is in patient goals. So again, being part of plans of care and care conferences. So, as I mentioned, they're a key component of this shared plan of care. Up to now, they've had very informal use at Eskenazi. Within EPIC, the electronic record we use, there is a capability to document patient goals, but it's not, current providers are using and team members are using this informally and in a non-standardized way. There's a limited taxonomy that's come out of the box from EPIC, which is pretty limited in the types of goals that can be documented or categorized out. And there's no aggregate understanding of the patient goals that are being set through these care conferences at Eskenazi. So in looking at the literature, as anyone likes to do, just jump into PubMed or try to find what is there right now. I was looking at the structures for patient goals in this care coordination space. So a few references that stood out. One is from the 2002 annual AMIA Symposium entitled Information Model and Terminology Model Issues Related to Goals. And they were looking at how to define the semantic structure of goals. And they concluded that there was no standard for a terminology model. And actually the big thing was that goals are similar to reporting results that have happened in the past, except goals are anticipated results. And so they had identified, or they were looking like at SNOMED and LOINC. One of the things that they had said about LOINC, and these hopefully aren't too much fighting words here, but they said the clinical LOINC semantic structure and another one are currently insufficient to differentiate between actual and expected findings, but offer an excellent starting point. So they were looking at what the landscape was there and finding that it was hard to express in a structured way what patient goals were. So fast forward a few years, and we have a paper in Journal of Biomedical Informatics in 2017 entitled Next Generation Terminology Infrastructure to Support Interprofessional Care Planning. Here, they had a sentence that I think is telling. They said, requirements for meaningful use and the Joint Commission include documentation of goals, yet no controlled terminology provides a mechanism for coded documentation of these concepts. And it sounds like a bit of a pattern where there's a mandate to do something, but not really a good way to do it. And so they had proposed a structure where they used a SNOMED concept of goal setting and combined it with a clinical concept code and then a time frame qualifier. But they said this is a space that is lacking. There's a gap here. There is another interesting paper, and this was done locally here at Riley, and this was about care coordination using a shared plan of care approach. And this is from Gina McAllister. She and her team implemented what we consider the Cadillac plan of care coordination for children with neurodevelopmental disabilities. They had a long, extended conference time with families, negotiating a plan of care with other care coordinators, calling, and a lot of intensive follow-up. One of the really interesting things from this is that they amassed over 250 shared plans of care, and then she and her team reviewed those and the 800 goals that were set in those shared plans of care for different themes. And the themes that they came up with through a qualitative thematic analysis included, and now again, these are specific in the pediatric complex care space, but included getting the right intervention and treatment, paying for healthcare and related needs, quality of family life needs, access and communication across complex healthcare systems, getting an appropriate education, understanding the diagnosis and treatment, and meeting basic needs. And a few examples of these, they had the headers and then some examples and subcategories under that included, for example, in paying for healthcare and related needs, accessing funding, insurance and related programs, managing out-of-pocket expenses, accessing other types of waivers and financial support, under getting an appropriate education, access to early intervention services, health action plans for school, things like that. There's also another space in this patient goal area, and that is with FIRE, our new favorite thing. There is a resource goal. These aren't super mature yet, but it's good to see this space being put down. They have several different components of this resource, including the life cycle of the goal, how far, what's been achieved, the category description, a target measure using LOINC, target detail, some other descriptive note stuff. One thing that's interesting here is that the value sets for these categories have not been well defined. There's, at least on the FIRE site, there's just a few sample ones thrown up, but I'm not aware of other value sets that would work well to identify and categorize these patient goals. So what I am wanting to do is to introduce a goal taxonomy. I want to look at what goal taxonomies there are. For example, Gina McAllister's with those 7 thematic concepts and sub-goals, and implement what I can find into a workflow and then iterate over that to find, are these goal categories working? Do we find that some aren't used? Why are they not used? And iterate over that. I hope that by introducing these, we can aid data capture for learning, so we can get aggregate goal insights. So once we have a discrete or some type of structured form, we can more easily sum that up into more population or panel even level insights into our goals. Once we have some type of categorization and knowledge of common goals that apply to a certain population or certain patients with specific needs, we can use that in decision support to help set goals. For example, if we know a child with a certain neurodevelopmental disability commonly needs or commonly sets these types of goals, in setting goals for a new patient with similar characteristics, we can say, hey, we should address these different types of goals. These are the ones that are commonly needing to be addressed if they apply. We can also prioritize health system resources by monitoring on a more population level. We can see if in one example, if our education goals are not being well attained, and we can dig deeper and maybe find that we need to invest more into our education and school liaisons. And a big thing that I want to do in the kind of stepping back and zooming out a little bit is to gain expertise in this method of applying or introducing and building the infrastructure for a learning health system and learning cycles. So with that, I think we have about 12 minutes left. I would love to entertain questions or hear feedback on these things that I presented. I have several questions to prompt with, but I'm going to reserve that slide until we've exhausted any kind of open time for questions. Eric in the back. Oops. No.
So I don't see there a situation for life planning. I'm surprised to see that's not there on the end of
That sure seems like a valuable proposal. What I think a next step that I would do is to work with Jeannie and see if we can get into the data more to identify these subcategories. I don't think these were developed with the goal of having a reference terminology, but I think with a good informatics perspective, we might be able to do that and maybe capture other subtleties that weren't, or broaden this out to include things like end-of-life care. Steve?
I think this is a really interesting challenge to take on. Earlier, you had mentioned to me an example of what Epic has in their goals, and the example you gave me was setting an A1C goal, which is very medical and sort of interesting. I looked through this set of themes, and they're not very medical for the most part. I mean, there's not setting a goal there. And that's more an observation, but it made me think about the complexity of the task ahead of you. And I wonder if you have thought about a sort of protocolized process that you want to follow. You know, you'd mentioned iterating on these things. Have you thought about what your protocol will be for running these cycles, you know, knowing when it's time to update your list, your mechanism for updating your list, your process for curating which new terminologies belong in your taxonomy and which don't, and when you've duplicated too much, you know, that sort of thing?
That's a great question. No, I have not set that down, but that is a to-do that I will take away from here to have that idea, being a little flexible in that, but having a bit of a protocol to say, this is when we are going to kind of harvest the data that we have right now. But you're right also about these goals are more family caregiver focused compared to the healthcare team's perhaps medical goals. And it brings up a good point that in this care conference, in this care coordination, there's a shared plan of care. And it's specifically stated that these are shared and they are negotiated goals. And so it's working with the family. So hopefully the family understands why there's a medical goal of an A1C of whatever, or some other kind of medical goal. But yeah, thanks. Laz?
Two things, two suggestions. Number one, in geriatrics, 2019, I think there is now a payment mechanism to develop a care plan and pay for it, like for dementia. So this is just for dementia. And you won't be able to receive the payment if you don't specify goal of the patients and goal of the caregiver. So that just FYI, you might get benefit from what's the requirement for that code, what can you do it for that piece. The second one, I know you might have looked at this already, which is technically right now the payment for advanced care planning. So there's now 30, you know, you can bill for $30 for Medicare of advanced care planning. And I bet in that advanced care planning, there might be something emerge of goal of care. So that's like just context. Now from an informatic perspective, my understanding, you're gonna try to focus on taxonomy and categorization, and technically moving unstructured concept to relatively structured concept. Where my understanding is the field is going back the opposite, with very significant advancements in NLP and using and everything. There's been now more toward like, you know what, don't worry about it. We will have a good NLP or verbal to actually create an individualized goal from whatever text you're writing down. And I think that might be a good area to see, do you really need to protocolize in taxonomy for storage, or is the NLP can be used as a methodology to make it easy? And the reason is because if you protocolize it, technically go against the whole purpose of goal of care, which is supposed to be personalized. So if you end up giving me like a 8 list or whatever, then technically it will be easy for the person who entered the data, but it might not be completely relevant to the people. So for us in the Sandra Askenai Center for Brain Care Innovation, the way we process that, we have a family conference where we disclose the diagnoses. And during that family conference, the doctor get out, and then the social worker work with the patient family to actually write goal of care, and then they enter it as a text into a format in Epic, and then we'll go from there. But obviously the problem is later on, I don't really know how to find it and all these other things. But at least there's a process that we learned without the doctor being there. The family and patient felt more comfortable and actually expanding their goal of care instead of just hemoglobin A1C or stuff, to really say, look, I want to be attending my daughter wedding. You know, that is my goal of care. I don't want anything else. I don't want to leave to the nursing home or something like that.
Thanks, Malaz. I'm going to talk more with you about that. But I absolutely believe there's a balance between that unstructured and there has to be space for that personalization, but then also some balance with some structure to be able to gain kind of larger insights. Yeah.
So, Randy, Kathleen Unrow. I think the most, extreme example of a very protocolized care planning process is in the nursing home, where there are so many regulatory requirements of what checkboxes have to happen during these regularly scheduled care conferences, that there is a lot of criticism and concern, that it's not this shared decision making. This is such a broad concept that I'm struggling a bit to, without understanding more the population or a condition, or, because care conferences happen in a number of different ways in the inpatient setting, just trying to pull people together in the setting of a crisis versus outpatient regularly scheduled. So I think just trying to understand more of your population and focus, and then I'm sure you've looked at other settings, and we certainly could talk about the nursing home piece a bit more.
Awesome. Thanks, Kathleen. Yeah. So this is primarily looking in the ambulatory and the outpatient space, not crisis, emergency family meeting in the ICU types of things, more in a controlled, planned, methodic type of setting in the outpatient space. But I'm trying to be open to how these kind of processes could apply to other settings in the nursing homes or others. I've kind of started in this pediatric space because it's the familiar area, but I hope that these processes can be flexible enough to be adapted elsewhere. But thank you. Yes, that I would not want this to be a checkbox exercise. Yeah.
Hi, maybe I missed it, but by creating this taxonomy, my question is, I'm kind of looking to understand what insights you want to gain from having this more structured way to put it, because from the way you described the care conference and the personalized plan, there's some implication that there are people who are reading and balancing the patient's goals versus the care to get them better. And so is it just an efficiency thing to make it more structured, or is it for technology to be able to auto-generate a plan, or is it, is it a time-saving thing so that the physicians and the healthcare providers don't have to read the full goals, like the full detail? Or I guess that's my question. What exactly is making it more structured? What is the insight? And I might have missed it in your presentation.
Oh, no problem. Thank you. So a little bit of, I can kind of touch on all of those things. There is an efficiency component, and not to the level that Kathleen brought up of, we just do the checkbox exercise, but an efficiency component of being able to enter and to track the goals. A big incentive, I think, would be at the more population level of understanding how goals are being accomplished, where they're being set, and where priorities might need to go at a larger level than just the individual patient level. Yeah. Awesome.
Let me just add one. Let me just add another thing is when you leave complexity is communication between different team and outside institution. That is getting very hard to spend all the time in my family conference where we set up, but the patient gets seen by St. Vincent and they have no idea that we set this up, and then they end up patient and family in crisis, as you know, or even outside. A lot of time they say stuff just to make the doctor feel better and things. So they might not convey, and so there's a lot of lost opportunity and confusions because of not able to, kind of track this. And then the big one is there's no accountability outside of just writing to say, am I actually accomplishing that goal? And is my clinic run by Dr. Bustani do much better goal, this concept of aggregate, than the clinic run by Kathleen or other person? Not as a judgment, it's more like just to trying to know, why Kathleen is doing much better in making sure the care is aligned with the goal. 100% of her, patients and family, their goal is complete agreement or other. So these kind of things that require coding and everything else to help the patient. That's at least when I heard you.
Absolutely, I agree. This helps us measure our patient-centered care too. Okay, all right. A quick question?
Well, sure, quick. I just want to bring it back quickly to the idea of control terminology. This is David Bayardo with the LOINC team. So, I just want to, just kind of point out that LOINC is a community, basically a community effort. And while the LOINC team does a lot of work and research when we get submissions, as you progress through finding what your set of goals are and develop your taxonomy, you're welcome to work with the internal team and submit it, and you can get it codified. So that's just to keep that in mind, for the future.
Great. I was hoping to hear something like that from the LOINC team.
Okay, great.
Awesome. Well, there were several other questions, but we don't have time for those, but maybe at some other point we can discuss those. So with that, thank you.